If we haven't formally met, I'm Chris Jaeger, one of the urologists here. Kind of wanted to start and just say thank you for what you do. You guys take excellent care of our patients, and if nobody said thank you today, let me be the first or the last of your shift. So thanks. My hope in this presentation was really to get an idea of what questions you guys had. So feel free to interrupt me periodically throughout if something doesn't make sense, or if there's something that you've been thinking about for the last 6 months and just haven't had the chance to ask one of us. But I hope that this is, I titled it Practical Urology because I didn't want to get into the nitty-gritty of anatomy and things that seem like they wouldn't really matter. But this is more when you're working with a patient, what are the things that you probably should be thinking about, or also what are the possible troubleshooting issues, and how can we fix that without having somebody have to go get another person involved or another service or something like that. So that's kind of my idea for the presentation. So hopefully this addresses some of the things. There's also an aspect of how to care and what exactly happened in some of these procedures that we do. Because I think sometimes there is a, here's what we did, and then, all right, good luck, guys. And I hope that that's not the case and that we're all kind of on the same page as far as here's exactly what happened, here's what you can kind of expect. And I mean, there's a huge variation in terms of urology care, and I think it's a little bit of a unique specialty in that it's a whole lot of plumbing and a lot of hand-holding, I think. And so anyway, I think it's probably different than a lot of other services. I don't know, you guys tell me, is urology pretty unique as far as surgical care, or is it, or?
Sometimes.
Sometimes? Okay.
Sometimes, it depends on the person.
Okay, sounds good. All right, well, let's get started. So we kind of talked about how I think it's a little bit of a unique specialty in that you've got catheters that need to be, watched and irrigated, and it's just kind of a different feel of a post-operative patient. I put on here common sense reigns, and that's really true. There's a lot of things that when we step back and think of it, it is kind of a plumbing system. And so if a catheter's not working, there's always a mechanical reason for that. So it's either the faucet's not working, so kidneys aren't working, or it's a plumbing issue, meaning that there's something blocking or kinking off that tube. And so I think sometimes even for myself, like when I step back and think, well, what are the possible issues that could be going on? There's usually one of two things, and we just need to kind of work through the pathway of what could be going on here. The other thing that I thought was important about urology surgical care is I think it is transferable. I don't know if you guys appreciate how many different consults and calls we get to other floors to come and fix a catheter problem or a misplaced catheter or something of that nature. Sometimes I think when we're involved in urology, including all of you, we probably get an idea like this is like easy. What's the problem? Well, a lot of people, a lot of nurses, a lot of doctors have no idea how to manage a Foley catheter. And so it's a skill set that if you ever end up not doing urology, it's probably pretty valuable to be. I don't know if you want to be that person that knows everything about a Foley catheter, but I do think that there is some real value in being able to troubleshoot some common catheter issues, difficult catheter scenarios, and even having a patient that has a catheter for another reason, they just had a surgery and they're in retention, and kind of explaining to them what exactly that's going to be like, what their urologist might tell them going forward. I think that stuff is really important, and probably most patients that we see in the post-operative setting that had a different operation or were in the hospital with retention, they had literally no idea kind of what to expect going home outside of, I just take this bag and I open it up and it empties into the toilet. They there's not that connection between like, how long is this going to last, or what are my options, or what's going to happen next. And so I think you guys are in a unique situation in that you see that every day, all day, with some other patients, but specifically with our urology patients, it's kind of a different feel of, I said a hand holding, but I do think that there's a little bit of hand holding that goes in, especially with some of these men that end up having catheters for a little bit of time. All right, so here are kind of the big three topics that I really wanted to touch on. Number one is can you guys see this okay? Okay. The difficult catheter. Number two is the procedure a TURP or a resective type of procedure, or we call it an outlet procedure sometimes because there's a couple of different ones that we do. But basically the gentleman that had issues with urination ended up having a surgery like a TURP where we go and resect open prostate tissue, maybe even a urolift, which is a newer technology that we use. I wanted to talk about bladder irrigation and voiding trials. And then the third one is the postoperative RARP or a prostatectomy, that's the surgery that we do for prostate cancer. You guys probably know that. Okay, so urinary retention, I think the number one thing to always remember is it's not always retention. And has anybody ever done a bladder scan and gotten a greater than 999 and then put a catheter in and nothing came out? So that bladder scanner is not a perfect tool. It's an okay tool, but I think the keys a lot of times are to always ask, why does somebody want this catheter? Why is the physician asking for a catheter or a bladder scan? And number two is, what am I going to do if this shows that it's high? And the reason is we see quite a few patients, and you guys probably have seen these too, where somebody says, hey, the scan shows 200 milliliters, and doctor said to put a catheter in. Well, for a vast majority of patients, especially our older men, and this probably more applicable to when you're on a non-urology floor, but these guys live with 3 to 4 ounces in their bladder, sometimes even 10 ounces in their bladder, and have zero symptoms whatsoever. And so that is their normal baseline. So I would just always encourage you to say, you know what, if you're talking to a physician that wants to put in a catheter, I think the common answer is reflexively put something in and drain that bladder. But the real answer is that's that guy's normal baseline, and if we put a catheter in, there's always a risk of causing a problem. Anything from we can't get it in now, and we got to do a procedure to get it in, all the way to, hey, we put this catheter in and actually caused him to have an infection, and now he's sicker than whenever we brought him in. And so the catheter going in is not always a big deal, but the question of why it's going in is always important. So if it's for kidney failure and we need bladder decompression for that, absolutely. But if it's a gentleman who maybe says, hey, I just had a abdominal surgery, and my urination's not like it used to be, but I'm still emptying, but I'm not that bad, and we scan him and he doesn't have a liter of urine in his bladder, I think the answer should probably be leave him alone and it will get better, rather than we try to get a catheter in. And that's just as much on physicians and NPs and providers as it is nursing care. But I do think that at some point you guys can speak up and say, hey, look, this guy's asymptomatic. He doesn't have any problems at home. He's really not having any problems here in the hospital. Why don't we kind of hold or drag your feet on that? And a lot of times that issue will resolve on its own. The other reason why you might see a patient with a really large bladder scan is that scanner is just a very basic, pretty bad ultrasound. And so all it's doing is picking up fluid. It's not picking up a true bladder volume. We call it a bladder scanner. It's a little bit of a misnomer, and 90% of the time it's picking up your bladder. But the reality is if you have a patient in heart failure or with liver disease or a huge amount of pelvic fluid, that scanner is going to read greater than a liter. You're going to throw a catheter in them, and there's nothing that's going to come out. And so they may not actually be in retention. So that's where kind of that next question comes in is why are we putting the catheter in? Do they really need this? Are they having problems? Because we put quite a few catheters in people sometimes that just didn't really need one. Any questions about that part? Okay. We talked about symptoms, kidney failure. Those would be real reasons to want to monitor ins and outs, and to probably have a catheter to rule out an obstructive process going on from the outlet of the bladder. Let's move on. All right. The female retention is actually pretty rare. And the reason is the female urethra is way shorter, as we all know, than the male urethra. But there are a couple of reasons why you might need to have a female catheter put in for retention. One of them is some of these older women can occasionally have a lot of vaginal atrophy that happens. Their estrogen is gone, so the normal tissues down in the vaginal area start to really get dry, and if you've ever tried to put a catheter in a really older woman, the urethra, or the tube that we're trying to feed this into, retracts, and it feels like that area is way up inside the vagina. And so that can make a difficult catheter placement for a female. So one of the most common tricks, and probably the easiest one to do, is to actually, if you're having trouble with one of these older females, use a coude, which is the curved tip catheter, just like you would in a male that you're having trouble getting a catheter in. Use a coude catheter and just place if you're right-handed, place your left finger inside the vagina, and then the only hole that you can really hit is that urethral hole. And almost 80 to 90% of the time it'll go in. It's pretty unusual for a female to ever have a stricture, which is kind of the thing that we usually talk about with difficult catheters in men. It's really unusual to have a female stricture. And so, if that's like one of those tricks where, you guys might get called from other floors for a difficult female catheter placement, and almost always it's a relatively obese female that's in her 70s, 80s, or 90s. And if you put them supine on the bed, have them just frog leg, and place a finger inside the vagina and slide a coude catheter over your finger so that the tip's upward, just like you would in a male, it'll almost always go in. So little trick. The other kind of tricky part about females is if they are truly in retention, it's probably a bladder that doesn't work very well, because the pressure that females have to generate to urinate is significantly less than men, because they don't have a prostate, and the urethra is a lot shorter. And so I think as far as counseling goes, just be careful about how you would phrase. You guys are talking to patients all the time, and you're getting to know their family and kind of having to counsel them along their medical journey here at St. Luke's. But the reality is when females have retention issues, a lot of times that's going to be a pretty significant underactive bladder, and it may never get better, especially when they're old. And so the question that we are always kind of faced with when we see these patients in more of the outpatient setting is it's a little bit of a tricky conversation, saying we have no idea if this will ever happen again. You may live with a lot of urine in your bladder, and as long as you're not having recurrent infections or leaking all the time, we're kind of okay with that. And we just won't have you live with a catheter for the rest of your life. But that may be some of these women's reality. If you're that far along and you can't pee and you're having issues, that bladder's probably not going to work, because it doesn't take a ton to empty out the female bladder. Okay, so this is kind of my difficult catheter slide. There are a couple of different reasons why we might have trouble putting a catheter in, and I can guarantee that all of you have probably seen every single one of these at this point. Again, the big question is, well, why are we having trouble getting this thing in? The most common reason that you would have trouble getting a catheter in a male is the prostate. And so the number one thing that should kind of go off in our mind as far as where is this getting hung up is most likely in the prostatic urethra, which is the portion of the urethra that sits right underneath the bladder. And if you think about the urethra as essentially a sink trap, the bottom of the sink trap is called the bulbar urethra, or the bulb, and that is located basically right around where the bottom of the scrotum is. That's the bulb of the urethra. So typically, whenever you're trying to put in a catheter, you can actually feel down there and usually feel the catheter go past the bulb, and then you can't get it into the bladder, and that usually means that it's a prostate issue. The other thing that is good to know about that bulb is if there's going to be a stricture or a scar tissue that's built up, it's almost always in that bulb. So when we do surgeries on males for prostate surgery, or when we do just a small cysto case and they end up with a stricture or scar tissue that's built up, it's almost always in that bulbar area. And so typically that catheter is just going to go in only about halfway, and you're going to meet a lot of resistance, and it's going to feel like a brick wall. Okay? Another reason that we always want to kind of question why is there's some history that's available to us, usually, unless the patient can't give it or their family's not there, about that might trick us into thinking, hey, here's kind of what might be going on. And the big ones are, have you ever had radiation? We see quite a few prostate cancer patients here, and if men have had prostate radiation, their chance of a urethral stricture goes up tremendously. And so, anybody that's had radiation, in the back of your mind, think, oh man, if I can't get this catheter in, there's going to be a good chance that there's a stricture there. And I'll talk to you about some different tricks there. The other thing would be, have they ever had a prior prostate surgery? So if your patient has had a prostatectomy and it was done 3 to 12 years ago, there's a decent chance if you're having trouble getting that catheter in, they don't have a prostate, so you've kind of ruled that out. The only other great option that they've got that could be going on is probably a stricture or something called a bladder neck contracture, which is basically a stricture, just the prostate's gone, so the bladder neck scars down and you can't get a catheter through it. That's where that new opening was made to connect the bladder back into the urethra. Another common reason why there's a difficult catheter is if that patient has been catheterized recently, or I think a lot of times what we probably all get is the guy came into the ER, couldn't pee, and they couldn't get a catheter in. The guy was reasonably comfortable, and then they sent him up to the floor for observation, and then it's your job to get the catheter in. Well, what probably happened down in the ER is they had somebody aggressively try to get a catheter in there and used likely just a straight, regular catheter. They just continued to push and hubbed that catheter, but it wasn't going into the bladder, and then all at once you've just got a ton of blood. And so what happened in that scenario is they false passed part of that urethra. So usually where that's going to be is right before you get to the prostate gland. If you think about the sink trap again, you made it all the way down, you got it past the bulb of the urethra, and then you went up into the prostate, and you've got to get over another tiny little, well, sometimes tiny, sometimes huge hill in order to get that thing up over the prostate gland and up into the bladder. But if you think about why those coude catheters work, is if your coude, you always want it up towards the head, right? The head of the patient. And you want it pointed upward. Well, that's because that natural curve kind of tips the scales in your favor and gets it up over the prostate gland. But if you don't have a coude, that catheter tends to just want to dig in. And so if that guy's got a big prostate, you're just kind of digging into the prostate gland. And so that's usually what's going to occur whenever you get a call that says, yeah, this guy was in the ER, he just had a heart attack, but we also couldn't get a catheter in him, and now it's just bloody. Well, most of the time, he got false passed, and it's going to be a difficult catheter. There's a couple of tricks that you can do to try to get one in. Number one is the damage kind of was already done. So whatever you do, you really can't make it much worse. The tendency, though, is that every time the catheter that you try to put in wants to feed into that little hole that's now been created. And so we've got to get something around that. The tendency whenever you have a difficult catheter is to always think, hey, I need to go smaller. It's probably a stricture. And so here's my number one tip is don't trick yourself into doing that. The answer is never to go smaller. The answer is always go up in a size and use a coude. And a lot of times if they tried a 16 down in, or even a 14 or a 16 down in the ER and created a false pass, you can usually use a bigger catheter like an 18 coude, and almost always that will be enough of a strong catheter to actually make that bend for you, and you can save that guy a lot of heartache. He's probably going to feel really, really good after you're done and his bladder's emptied. And most of the time, whenever that happens, if you got an 18 in him, he's going to feel a lot better, and there's really not going to be a whole lot of blood that comes out of the bladder because it was all inside the urethra. Make sense? The other ones that I kind of wanted to touch on were buried penis and phimosis. These are tricky. The buried penis is a tough one because really it's not so much an anatomy thing as it is just trying to get the catheter started. And so grab a friend, and one person probably needs to be up around the patient and pushing on that fat pannus to try to get the penis as exposed as you possibly can. And you usually can do this, but oftentimes these are the guys that weigh, 400 to 500 pounds and are in heart failure. And so they're very swollen and you just have trouble getting that catheter in. But more often than not, the key is not just trying to fish around for it, but instead, if you can get somebody, or you be the person that pushes just around, make your hands into a diamond and push on the fat pad that's there and pull the pannus up, the penis will usually get exposed and you can quickly put in a catheter. And sometimes that doesn't work, but that's a nice first step to try. But these guys are just tough because you can't see what you're doing. Phimosis is another one that is just if a gentleman is not circumcised, the foreskin of the penis comes down over the head of the penis, and you just can't see the actual hole of the urethra. And so one thing you can try in these guys is gently pull as much of the foreskin back as you can until the guy says, hey, that's probably enough. And then you can try a smaller catheter in that instance if it's really tight and you want to try to get a catheter in. These are tough because oftentimes they require like just a little bit of dilation, and we usually use like a little hemostat or a little clamp to open that up. It's not comfortable, but if you can get anything in to a smaller area and try to feed a catheter in, that's probably the best bet. But almost guaranteed, if they have bad phimosis, you're not going to be able to get a 14 or even a 16 French catheter, and you might even need to use a small little 12 or 10. So I wanted to include a little bit of, here's what we see whenever whenever we're doing procedures and there's stricture disease. So this is kind of what we were talking about earlier, is this area right here is the bulb of the urethra, the bottom of the sink trap, and you can almost always get a catheter to this area. If you're having trouble before then that's probably a stricture higher up inside the urethra, and you probably need a urologist at that point. But if you can get it to here, you can see right after you hit the bulb, that's where the strictures or those tightened scar tissue usually forms, and you're gonna have trouble getting it the next 5 to 6 centimeters up through the prostate. Here's kind of what it looks like, is this is the hole that you're shooting for. You can see these are tiny, like these are the size usually of those wires that we bring up to put, to do dilations. They're really tiny. You're trying to feed a tiny little hole with a wire or a catheter. So you can imagine if this whole urethra is like about 22 French, which is kind of like the scopes that we use, that hole's probably 4 to 6 French. So that catheter's never gonna go in. So if you hit a brick wall, that's what's going on. And if you push really hard, it's gonna start looking like this. And so here you can see the hole on this has been opened up already, but imagine if this was your stricture and you started pushing a catheter through here. Here's kind of what it's gonna look like, is you're just gonna create a false flap. And then we've got to figure out how to get a wire through this area. And that makes it really tricky. And so that's where we tend to end up getting scopes and having to actually feed them in. And if you can't do that, then you got to drain the bladder through the belly, which is a suprapubic tube. But these are just nasty because they almost always come back. And so if the guy has a history of a difficult catheter placement, if you're sitting there in bed and he's in retention and he goes, yeah, you know, I've had this done before and they had to use all these special tools, usually that's a reason to give somebody a buzz after you try gently. I wanted to include this picture mainly just, this is, if you think about it, the navigation that you have to do to get a catheter into the bladder. Here's the penis, here's the bulb. We talked about that being right underneath the scrotal area. So here's the bottom of the scrotum, and the bulb tends to be kind of right in that area. You can almost feel it underneath the scrotum. And then you've got to make an upward trajectory, and if this prostate's really large, sometimes you even have to make a forward trajectory to get up around it and get into the bladder. So that's kind of what we're dealing with as far as the anatomy goes and why there might be some difficulty with the prostate area. And then here's another picture of a false passage. So this is the true urethra, and then right here is the false passage. And as you can imagine, this catheter just kind of went off track, and every single time that you go and try to feed that catheter, and it's probably going to want to go back into that wrong track. So somehow you've got to right the ship, and if you can't do it blindly, then you end up having to use a scope. Here's the buried penis that we all just don't like to see. I put on here some kind of little tricks that might help if you run into a difficult catheter. One of the keys is make sure the guy is relaxed. Another reason that sometimes the catheter can be difficult to put in is if they're really amped up and nervous, they're going to be squeezing as hard as they can, and any little sensation down below, they're probably going to start squeezing even harder, and you're going to think that there's something blocking it, but it's really just their sphincter, especially as younger guys. If you have trouble getting a catheter in a younger guy, it's usually just because they're squeezing so hard that it feels like it's not going to go in. So take 2 seconds, go, hey, take a deep breath and squeeze your toes. and then gently push that catheter, and it will almost always relax enough that you can get it back into the bladder. That's a really good trick for like a guy that's under 50. If they need a catheter, it's usually because their pelvic floor is really tense and they're just nervous and they're squeezing their urethra so hard. The other nice little trick to know is to use tons and tons of lubrication if you need it. You know, these catheter kits that we all use, they come with one 10 cc syringe, which is okay and it works about 99% of the time. But if it's a difficult catheter, don't just grab one of the little tiny lube packets that's available on the floor. Grab 6 of them and empty all of them onto the tray. The other trick is you can actually inject the lubrication directly into the urethra, and that will often give you a lot more lubrication and slippery surface to actually feed that catheter in. And that's a nice, easy trick that doesn't involve any pain, and the patient thinks that, you know, you're maybe giving them anesthetic into the penis, even though it's just lubrication, and they're usually a little bit happier. Okay, so we talked about this again. I can't stress enough. If you have trouble getting a 16, go up to an 18 Coude. If you have trouble getting a 16 straight, go up to an 18 Coude to try first, because it's almost always the prostate, and the 18 Coude is a lot more likely. It's a stiffer catheter, and it's more likely to make it up over the prostate. We talked about pushing down on the penis. If the patient's anxious, try to walk him through it. And then last but not least, you can always contact one of us, and we can put in a catheter. Okay. Any questions about any of that? Have you guys heard any of that before? As far as catheter sizes and things? Not to go up? Okay.
We love Eurojet, and
Eurojet's great. You can put that directly into the penis.
policy to inject into a male urethra the lubrication.
Changed it for the better? Like you can do it now,
Yeah,
or?
like you should put it in the.
Oh, good. Okay.
Yeah.
Yep. So a TURP is, I think we all know, is this procedure that we do, and this is a electrocautery loop that we're using to basically open up that prostate channel so that a male can urinate again on his own or improve his urinary symptoms. So it is a surgery where we're removing prostate tissue. Basically, these patients have a wide open hole where the prostate used to be. We've all done this. This is kind of the mechanism of bladder irrigation. The reason we do this is because after a TURP, patients tend to have a really vascular prostate. There's no great way to apply pressure to the prostate. And so most of our TURPs will come out with a catheter on a little bit or a lot of traction. So it's taped to their leg, or they have a stat lock that looks really tight. The patient's going, man, this thing really is uncomfortable. And there's a reason for that. Is the only great way to put some pressure on the prostate is to tug down on the catheter and have that balloon compress things. I personally kind of like to use the fruit or vegetable way to describe blood in the urine. It just feels right, and it's easy to interpret. So, you know, they give these grades of hematuria. I've never called it grade 5 hematuria, but I have called it cherry or fruit punch or watermelon or peach. And so, I don't know, that's kind of helpful to me. I don't know if there's a huge wide variation in how people describe blood in the urine based on urologist, but I don't think you can ever really go wrong. Most of us, I think, in training learn the watermelon, peach, cherry, red wine type of nomenclature.
I didn't even know there were numbers.
Yeah.
We always take beverages.
Okay, good, yeah. So when you're describing things, that's usually pretty helpful, and you guys normally do a great job of that. Here are some irrigation tips, and these are things that I think are helpful, especially if you don't deal with catheters all the time. These are other things that nurses, in other places in the hospital just have a really hard concept grasping what these mean. Like, let's say that somebody had a cardiac ablation and they had a catheter afterwards, and they heparinized them, and all at once the urine turns cherry color. Well, telling or putting an order in that says irrigate is needed to you all means, well, if it looks like it's turning darker and they have clots in it, I probably need to irrigate this catheter. For some other floors, it means every hour I'm in there pushing fluid in and out, and they just don't need to do that. But I don't know if you know that unless you had some experience on a urology floor. So, we always try to tell nurses that you want to use the big port. If you have a 3-way catheter in, don't use the tiny port. The tiny port's just for the irrigation fluid, but you can take apart the device and actually irrigate that big port, and you can aspirate as well. And the aspiration is the key part because that's how you get the clots out. If you're pushing fluid in and you're irrigating, you're just dislodging the clot that's blocking things, but doesn't get it out of the bladder. And so a nice firm pull on that syringe will help pull the clots out a lot better than just irrigating. And then I think the other important thing is, if you ever get into a place where you just can't irrigate a catheter on a guy that had a TURP or a prostatectomy or something like that, I think probably the most appropriate thing would be to just give that surgeon a call. And the reasoning is usually we can remember why that thing was in and how difficult it was to put in. And there's some TURPs that you did a TURP and they had a really tough time at the end of the case getting a catheter in, and it might be worthwhile trying something different, or even sometimes putting a wire up through the catheter before you exchange it so you know you're back in the bladder. And especially on prostatectomy patients, those guys are always at a risk for that connection that we made falling apart. And so we want to kind of know about that. Okay. As far as voiding trials go, I don't think I've ever really had this issue, but whenever you fill up a bladder, you want to give the patient enough time to urinate. And really, as long as the urine is clear, that patient should be able to go home with or without a catheter that day. I think the key is, if they're urinating, they get to go home without a catheter. If they're not, we usually put it in and leave it in for at least 3 to 7 days to kind of let things heal a little bit and let the swelling go down, and then we'll take it out, and almost always they can pee afterwards. Okay. We're going to move on to prostate surgery for cancer patients. So we typically are doing prostatectomies in patients that are a little bit younger with a more aggressive prostate cancer. So these guys are typically reasonably healthy. If they're really unhealthy, usually we don't take their prostate out. We usually give them radiation treatments. But there's really not a whole lot. I think you guys do an excellent job, because we see a lot of prostatectomy patients here. But I think you guys do a really good job of counseling, and 95% of these patients do leave on postoperative day 1, which is fantastic. I mean, there are a lot of barriers to getting somebody out of the hospital after they have a major operation. I think it helps that you guys advance diets quickly. So it's an abdominal surgery, but at the same time, it takes about 2 hours, and they're usually feeling reasonably well in the afternoon on postoperative day 1. The catheter is something that they all probably have to get used to. And again, they're younger guys, so they're a little bit more sensitive to sensations down below. And the only other thing that I would kind of mention in the postoperative course is the biggest reason why our patients, if they ever get discharged and end up having to come back to the hospital, is almost always constipation. And if you think about it, they just had an abdominal surgery. They've got a catheter in that kind of makes you feel like you need to go to the bathroom more often. They've been under anesthesia. and they've been getting pain medication. And so I can't stress enough, we try to tell them as they're leaving, but as you're doing discharge on these gentlemen, just remind them, hey, pick up a stool softener on your way home, and it will do wonders for them, because once they have that first bowel movement, I think usually that's when they start to turn the corner. But if they're going to call and have really bad abdominal pain, it's almost always gas and constipation pain. Any questions on anything? I tried to make it as practical as possible for troubleshooting. Yeah?
What's the biggest thing, like in the middle of the night, of things that you want to be called on in regards to your post-op patients, instead of calling, say, the surgical house? If we have surgical house at night. No. What are the biggest things that you want to be called on?
I mean, I guess, the catheter not working would be something that we'd want to know about. I mean, if the patient's not doing well, like, if you're looking in there and their heart rates, if they're tanking or crumping, we would want to know about that. We might say, hey, call the house soup because I can't be there in the next hour or something. And then I think as far as this stuff goes, like prostatectomy patients, really the big thing would be if they're not doing well. I mean, they should look pretty good day one. So I mean, if their blood pressure is way down low, their urine output's almost minimal, or they're just looking really, really ill, that's not a typical post-op prostate, and you got to start thinking about what's going wrong here, because they should look, they should look pretty good on that afternoon, and that evening they should look like they're about ready to leave the hospital, typically outside of just some incisional pain.
Things like elevated blood pressures, or that gas pain, and one is significant, or if you want us just to call surgical house on elevated blood pressures, I know low, we'll call you, but with elevated blood pressures.
I mean, I guess technically that's like still our service. I don't know. I always kind of interpreted surgical house as like, hey, we need you in an emergency. Maybe it gets utilized more than that, which is fine. Do you guys call surgical house quite often?
Occasionally when they're like really whiny about gas pain
Or something just to help them sleep.
Okay.
yeah, just
I'm totally fine with that. I would rather get the calls just if there's something significant going on. So that's great. I didn't know that they were even available for that.
sometimes they are.
Okay.
There's times
Not
when they don't
every
have them
day,
at
but-
night.
Okay.
But they're helpful for those little things when they're just kind of, some of the patients are just a little bit whinier than others.
I would say I'm totally fine with calls for simethicone and things like that. I think if somebody is
AMS, that we could just, text you through that.
we can talk about that. I've told Katie about that. Every hospital has their own AMS, and so they're getting rid of it anyway. So it's another new app to download. Yeah. But yeah, I would say mainly hey, your patient is not doing well is probably the really appropriate call. I mean, the last thing you want is to have somebody transferred to the ICU and you didn't know about it till 8 a.m. You know what I mean?
Colorectal fistulas, what goes into treating those or maintaining, just watching them?
Kind of depends on how healthy the patient is. There's a lot of different reasons that those develop. The most common one is diverticulitis. Colovesical fistula? Yeah, diverticulitis. And then cancers. There can be like Crohn's disease or ulcerative colitis can cause them. And then a prior surgery like a prostatectomy, and then they've had radiation, and sometimes a fistula can develop. Typically, if it's a true like colovesical fistula from diverticulitis, you're just going to go in there, probably robotically, and usually we'll do that with a general surgeon, but the general surgeon will take the segment of intestine that's connected to the bladder and just excise it, and then we put a couple stitches in the bladder to close it and fix it, and then they connect the bowel back together and push it off into a different location. But post-op course is typically you're going to wear a catheter, kind of like if we put a hole in the bladder for any other reason, like if we remove a ureter and a kidney, you're making a hole in the bladder, and so you leave a catheter for at least 3 days to let it heal. But otherwise, not too much else other than it's actually more of a general surgery thing because you got to do the bowel. You want to make sure the bowel connection works again, so it's slow diet advancement and that kind of stuff. We just kind of get to look and say, yeah, the catheter looks good.
Can you talk through a patient that has hematuria and the CVI clogs and we can't get it clot? What you, in our position, would be doing at that point?
So I think the first step is, why is it clogging? Sometimes it's that there's still a ton of clot in the bladder, and usually at that point, if they're really distended, we're gonna usually get a like non-contrast CT scan and see how much blood clot is truly in the bladder. And then I would probably say make them NPO, because there's a decent chance that they're going to need to go to the OR to have all that clot evacuated out of there. But usually that's a call, and probably the next step is, depending on what size catheter they have in, almost always the next step is go ahead and put in the largest 3-way catheter that you have and irrigate, aspirate. The other thing I didn't mention that works sometimes is if you have a pretty big 3-way catheter in, if you think about the way that the catheter works is you've got this balloon at the end of it that's filled with fluid. Well, that balloon, to some degree with the fluid in it, does add some compressive effect onto that diameter that you're trying to irrigate through. And so if you know you're in the bladder, meaning the catheter was working at one point, you can actually keep the catheter kind of where it's at, deflate the balloon, and irrigate just like that without pulling the catheter out. And that will usually kind of dislodge some things because you have a little bit more to irrigate through. But upsizing, and then if that's not working and the guy's really uncomfortable, probably need to give us a call. But almost always they can kind of hold over into the morning. I think maybe one time in 7 years I've taken somebody in the middle of the night because it was just clotting and the guy was so uncomfortable. Yep. And then the other part is, Jason, irrigating and aspirating. So like, don't just push more fluid in. Try to aggressively pull out clot.
I know most of us have been there where they're so uncomfortable. Yeah. The call's out to the doctor, they're not called back yet. You know what I mean? Yeah. Obviously you shut the CD and they go, oh,
Shut the CD
I want more fluid. And is there ever times that maybe pulling out that it's going to seep some and release some of that pressure?
Usually not, but you can usually put in a bigger catheter. So I think if you're really in a pinch, I think taking the catheter out's a good idea, and then putting in, a 24 or 26 French 3-way will almost always kind of, at least it's a new thing that even if you get 50 cc's of fluid coming out that's then clotting off again, at least you got a little bit out, and then you can just start trying to pull clots out, but it's not fun.
We don't see them all the time, but when we do have an adrenalectomy, is there any big red flags to look out for?
Yeah, so the number one probably weird thing that can happen with adrenalectomy is an adrenal crisis. So patient comes back from the OR, does great for a couple hours, and then all at once their blood pressure's 80/40 and they're tachycardic and they look like they're bleeding, but you get you get a blood count and it's normal. They're usually in adrenal crisis and they need steroids and usually some ICU monitoring. They might feel really clammy and sweaty. They might look terrible. But that's usually what's going on. Now, typically you're going to know that they're not having that because you didn't take their normal contralateral adrenal gland makes up for it, but that'd be the only major thing.
Do you care if your patients are, when they go home, taking ibuprofen instead of Tylenol?
No.
Like a partial nephrectomy, does it matter? Or what?
Not to me. I'd probably ask the surgeon.
Because everybody's always asking that question. Why usually take ibuprofen? Well,
Yeah.
just take Tylenol.
Yeah. It usually doesn't matter.
Cool. Well, again, thanks for what you guys do. Yep.